Welcome to our STAT 220 project on quality of life analysis. Our project looks at Missouri County and city health data. Rates of various health and social factors were collected from Missouri zip codes. All rates came from hospital inpatient, emergency department, and outpatient cases in fiscal years 2014 to 2016. Additionally, rankings were provided for variables such as clinical care, health behaviors, socioeconomic status, mortality, and quality of life. In our project, we looked at the following rates: premature death, years of potential life lost, low birth weight, mental disorders, smoking, obesity, substance use disorders, teen pregnancy, sexually transmitted infections, assault, injury-related deaths, Medicaid hospital visits, uninsured hospital visits, high-risk mammographies, COPD, stroke, diabetes, hypertension, arthritis and joint disorders, kidney disease, heart disease, liver disease, atherosclerosis, asthma, various forms of cancer, preventable hospitalization, hospital emergency department visits, hospital inpatient visits, hospital outpatient visits, potentially preventable emergency department visits, and hospital emergency department after-hour visits. In our research, we hope to determine which of the listed factors are most correlated with overall quality of life rank. We decided to research this topic because many factors go into predicting an individual's quality of life. Although quality of life is somewhat subjective, it is defined by the Collins English Dictionary as the general well-being of a person in society, defined in terms of health and happiness. Social factors, such as insurance coverage and assault, can have just as much impact on an individual's quality of life as well-known health conditions such as heart disease and cancer. Missouri is ranked 40th in health outcomes among the 50 states, and we hope to learn about which factors may be influencing that ranking through our analysis.
We started by looking at the correlation between our variables of interest, quality of life, and all other variables. Moving forward, we just wanted to work with the few variables that had the strongest correlation to quality of life, so we identified the top 5. Hospital emergency department visits had the highest correlation, followed by potentially preventable emergency department visits. In order to get a closer look at these top 5 variables, we created scatter plots comparing each to quality of life. We added a line of best fit to each graph, and as you can see, they all had very similar slopes. Here is the graph for smoking, hospital inpatient visits, Medicaid hospital visits, emergency department visits, and finally, potentially preventable emergency department visit rate. All 5 scatter plots showed strong positive correlations. Each group had a horizontal asymptote at 0 and 1,000 because quality of life was a rank between 0 and 1,000. The scatter plots didn't offer a ton of insightful information, so we continued to investigate these top 5 variables. However, we did want to note 2 significant outliers that were present in our plots of emergency department visit rate and potentially preventable emergency department rate. In both cases, the outlier was found to be from the same neighborhood, just outside of Kansas City and West Bottoms. To see which variables most accurately predicted quality of life rank, we created 4 linear regression models. The first model, named Fit Linear All, included all 45 variables. Next, we created the model Fit Linear Back with stepwise regression. 18 variables whose removals lowered the model's AIC by the most were removed, leaving us with 27 variables. We then created the Fit Linear Top model with all 5 variables we previously identified as having the strongest correlation to quality of life. Finally, we made a Fit Linear LCD model with variables from the top 10 leading causes of death in the U.S.: heart disease, cancer, stroke, chronic lower respiratory disease, diabetes, and kidney disease. After creating our models, we then felt it was important to measure the quality of our models. We began by calculating the AIC of each of our 4 models that we created. We use the AIC calculation because it is a standardized way for us to understand how our models compare to one another. When running our AIC code, we found that our model, Fit Linear Back, did the best job at predicting the quality of life rank. We know this because out of all 4 models, the fit linear back model had the lowest calculated AIC. While the AIC is helpful for determining which model is the best, it does not help us to understand how good our best model actually is. To do that, we will need to continue testing our fit linear back model, which we will be doing momentarily. However, before we move on and simply focus on the fit linear back model, we wanted to run a cross-validated root mean squared error. We found that, again, our fit linear back model had the lowest score with a cross-validated root mean squared error of 126.7. This is not surprising, as we just determined that our fit linear back model was our ideal model by calculating the AIC. Because of the similarity in our findings, we felt it was now justified to continue by simply looking at our fit linear back model going forward. As we continue to search for answers regarding our research question of what variables had the most significant impact on quality of life, we felt it would be necessary to create a CART tree, as you can see here. We included 2 variables in our CART tree, the rate of emergency department visits and the rate of inpatient visits. We were quite astonished to see that the rate of emergency department visits had a positive correlation with a county's quality of life rank. We originally thought that if a county had a low hospital emergency department visit rate, they would have a significantly higher predicted quality of life rank, and vice versa. However, instead, having a higher emergency department visit rate corresponded to having a higher predicted quality of life rank. Similarly, we found this to be true for the hospital inpatient visit rate. This may be due to the fact that a county whose residents can more easily visit the emergency room would have a higher access to treatment and would thus have a higher quality of life rank. We then decided to run a random forest to allow us to achieve a better predictive accuracy when using as many variables as possible. We made sure to calculate the out-of-back error because we felt it was important to determine how well our method would perform on new data. We wanted to ensure that our model, FIT-RF, did not overfit the data and could be generalized well. Once calculated, we found that the out-of-back error for our FIT-RF model was 35.46. This meant that our model had about a 65% chance of accuracy each time it was run. Finally, we decided to obtain a list of important variables and then plot them accordingly. As you can see from this graph, there were 5 variables that were determined to be of utmost significance or importance. Those variables are located near the top of our chart: emergency department visit rate, potentially preventable emergency department visit rate, uninsured hospital visit rate, hospital inpatient visit rate, and Medicaid hospital visit rate.
From our analysis, it appears rates regarding smoking, potentially preventable emergency department visits, hospital emergency department visits, and hospital inpatient visits most accurately predict quality of life rank, as they appear in the output of many of the statistical analyses we performed. This answers our research question. These variables appear to have the largest effect on quality of life rank. There were a few surprising findings in our analysis. First, we were surprised to see so few health conditions in the top 5 important variables. None of the current leading causes of death, including heart disease, cancer, chronic lower respiratory disease, stroke, diabetes, or kidney disease, showed up as very important in predicting quality of life. When people think of health, they think of the absence of illness. This research proves health is more than that. Health is an overall sense of physical, mental, and social well-being. Interestingly, smoking had a positive correlation with quality of life rank. We hypothesize wealth may play a role in this relationship. Smoking is an expensive habit. Zip codes with residents who smoke frequently and are able to afford cigarettes may have a higher quality of life due to the county's higher economic status. Another surprising finding in our analysis was how influential uninsured and Medicaid hospital visits were for quality of life. Unfortunately, many residents in Missouri zip codes are unable to afford medical insurance. When access to care is limited, individuals face additional stress and fear because they don't know how they will pay the bills if they get sick or injured and need medical attention. They may avoid seeking treatment in an effort to save money and end up in a more serious condition. Further research into this trend may support the push for universal healthcare and healthcare reform in the United States. In the future, research should be continued to verify the most important factors affecting quality of life. Further research could be conducted to look at variations between zip codes. Does one health or social factor influence quality of life in one zip code more than in another? Research into social differences, such as wealth, residence location, and access to care in various zip codes could be beneficial to draw further conclusions as to what is actually impacting quality of life rank the most. Additionally, future research could examine the peculiar relationship between hospital emergency department visit rate and quality of life rank. In our analysis, it appeared the higher the emergency department visit rate, the higher the predicted quality of life rank. Access to care may play a role in this unique relationship. Counties whose residents have easy access to a hospital may receive treatment quicker than counties whose residents have to wait or drive hours before seeing a doctor. Therefore, having a higher hospital visit rate may correlate with a higher quality of life rank because residents have greater access to care to treat disease and injury. Finally, future research could be conducted to determine if the trends found in this analysis extend to other states. Other datasets could be used to better assess why quality of life measures and health outcomes vary between states. Researchers could answer the question, what factors have a greater impact on the average quality of life of one state's citizens than on another state's citizens? Thank you for your time, and we hope you learned something new from our presentation.